It's my honor to go after Dr. Potter and talk about, instead of benign gynecologic disease, malignant gynecologic disease. And I'm going to focus on CT and MRI because you spoke about ultrasound yesterday. So first, I'm going to start with a general overview about the role of imaging, CT, and MRI in gynecologic malignancy, because one of the intriguing parts of it, and the reason I enjoy doing it, is we have a very specialized role, and we work with the surgeons very closely. Then the general principles of imaging technique, and then specific examples from the common gynecologic malignancies of endometrial cancer, cervical cancer, ovarian cancer, and I'll briefly touch on metastatic disease. So first, a general note about the role of MRI and the role of CT is these are specialized problem-solving tools. Dr. Potter already talked about that ultrasound and clinical exam is usually the way you're going to primarily diagnose a gynecologic disease, and MRI and CT work when we have specific questions that we want to ask. So our imaging is always tailored at those specific questions. And this management algorithm you've seen before, and really what we're going to use ultrasound, or use MRI in particular, is also CT, is when the ultrasound doesn't match the clinical picture. If you have a clearly benign ultrasound in someone who is low risk, then that's benign. If you have a clearly malignant ultrasound in someone who's high risk, then that's malignancy and that's treated like that. If you have a concerning ultrasound in someone who actually has low pretest probability, that's where you'd want to do an MRI or CT, and similarly in a pregnant woman or some other just plainly indeterminate ultrasound. So the technical factors, imaging gynecologic malignancy is pretty straightforward, but there are very important technique factors that are important to know. And when we see MRIs from other places, or sometimes when our technologists make errors, it really comes from specific misunderstandings. And really the key cornerstone technique is a T2 fast spin echo without fat saturation. And that without fat saturation is very important. And also the tailored image planes are very helpful. The tailored image planes, first of all, this is an example of a patient with a cervical cancer, and in which getting an image plane that is actually perpendicular to the axis of the cervix and the axis of the vagina makes it easier to actually see whether there's extension into the perimetrium and minimize partial volume effects. But this is where communication with technologists has to be clear, because some technologists may not be familiar with the anatomy, or they may not be familiar with doing examinations in a certain way. And so sometimes, like this one, this oblique plane through the cervix actually ends up being oblique through the vagina. And even though in this study it didn't make a diagnostic difference, it's important to provide feedback, because there will be a future study in which it does make a diagnostic difference. The other issue with obtaining your T2 weighted imaging without fat saturation is extremely important. And this case, in which is actually difficult to read from looking at the images, is similarly difficult to read on the PACS because there's fat saturation, is we have a patient with a cervical mass, but you want to know if there's perimetrial extension, but all the vessels in the perimetrium are going to be bright on a fat saturated image. And so it's very difficult to see the well demarcated image planes on a fat saturated image. So making sure to have T2 without fat saturation is extraordinarily important. Moving on to specific diseases, we'll talk first about endometrial cancer. Endometrial cancer is the most common gynecologic malignancy. As you know, it presents with uterine bleeding and is related to unopposed estrogen. And of all the different prognostic factors that are important, the one where we play a role is predicting myometrial invasion and the amount of myometrial invasion. Endometrial cancer is an intermediate density mass. It's a little bit brighter than the myometrium, but it's darker than the endometrium. And you can see actually the invasion in the myometrium quite well. But sometimes contrast enhancement is helpful, particularly in postmenopausal women. The junction between the tumor and the myometrium can be indistinct. So looking for a mass, particularly on these delayed images, where you can see the boundary between the mass and the myometrium, the hyperenhancing myometrium, very well, helps. So there's the tumor, and this is a myoma, which is also visible on the post-gadolinium images. Another thing that can be very useful in endometrial cancer and gynecologic malignancies in general is diffusion-weighted imaging. Diffusion-weighted imaging hasn't proven useful quantitatively yet, but it is useful in identifying where a disease is in cases where it's difficult to see. So this is an example of a patient who has endometrial cancer, and there is a dark myoma, and there's some heterogeneous, ill-defined tissue here and perhaps some endometrium here. And it can be difficult to figure out which part of this is tumor and which part of this is not tumor. But if we look at where the tumor is restricted on diffusion-weighted imaging, has a low ADC, we can clearly identify that this portion is the portion that is tumor. And so that helps. And we'll revisit this idea of diffusion-weighted imaging being useful in detection later on in this talk. Key imaging features for staging: myometrial invasion, extrauterine extension, distant metastases. I stress with residents not to memorize the specific staging numbers, both because I have a hard time memorizing it myself, but also because this changes every now and then. There's always a revised staging system and a revised staging system. But the anatomic and characteristics of the lesion, those usually remain invariable, and those will correspond to a staging which you can look up. So first, the myometrial invasion and the degree of myometrial invasion in the present staging is actually the most important thing that we can help with. And greater than 50% myometrial invasion makes something stage 1B, but more important is the implication that this greater myometrial invasion actually increases the risk of lymph node metastasis and is an important prognostic factor and can change surgery. And these are post-gadolinium images. This one illustrates how a post-gadolinium image can be useful to seeing the degree of myometrial invasion. Extrauterine extension, of course, extension down into the cervix. This means it's stage 2, but more important to know this is why it's important to know. So if the tumor invades into the cervix, when the surgeon does their surgery and they go through the cervix, they want to make sure they're not going to cut through tumor. So knowing that there's definite involvement into the cervix can change the surgeon's surgical approach, and this is something that's important to discuss. You can also see metastatic disease, and on MRI this actually can be a little bit difficult. This is a patient with endometrial cancer and no clear extrauterine extension, but there is actually a metastasis to the inferior pubic ramus. So really the impact of imaging is to talk about prognosis. And sometimes these patients get taken directly to surgery, but our surgeons like to know a lot of this information beforehand. And we start with myometrial invasion, we go to distant metastases, and this makes a poorer prognosis, more extensive surgery, and maybe even preoperative chemotherapy or radiation or postoperative chemotherapy or radiation. So in MRI, it's really an adjunct to surgical staging, and that 50% myometrial invasion is key, and the diffusion helps to identify tumors. We'll move on to cervical cancer. Cervical cancer is the second most common gynecologic malignancy worldwide. It's associated with HPV, and it occurs in young women, 20 to 30 years old. And again, because this is a worldwide cancer, the defined staging system is a clinical staging system, but imaging has an adjunct role to play. The normal cervix has 4 layers. It's going to be the mucus is that inner layer, the bright T2, and then there's the mucosa, which is just outside of that, and the dark fibrous stroma. And that dark fibrous stroma is continuous with the junctional zone of the uterine corpus. And then the loose stroma on the outside, which is continuous with the rest of the uterine body. So in the imaging appearance, once again, it's this heterogeneous mass that's arising from the cervix. Very similar in appearance by itself from endometrial cancer, but in this case we have the dark stroma to contrast with it as opposed to this sort of intermediate muscle. There is described, and sometimes we see this early enhancement of cervical masses. I have to say we do dynamic contrast enhancement in our cervical masses, and many times it either misses it or doesn't display this early enhancement. And many times we don't see it until, just like endometrial cancer, on a delayed image you have a hyper-enhancing mucosa, cervix, and endometrium, and it looks like a low density mass. Here, the key imaging features, again, are local extension and distant metastasis, but size is also crucial when looking at a cervical lesion, because greater than 4 centimeters actually changes the prognosis, and many times these patients will get preoperative radiation therapy if it's greater than 4 centimeters. Parametrial extension, as you all know, is one of the key things that we say on imaging, because this is much more accurate on imaging than it is on clinical exam. The important thing about parametrial extension, which is interruption of this dark fibrous stroma, but not just interruption, but you actually have to see tumor in the parametrium. If that dark stroma is not interrupted, then there is no extension, but you can have interruption of the dark stroma, but still no tumor in the parametrium. It's important not to overstage these patients. The other thing is that you want those axial oblique image planes to be exactly perpendicular to avoid overstaging the patient. This is a true coronal, which it looks like there may be some parametrial extension, but if you look at the axial oblique, which is an image we saw earlier, there's clearly no extension outside of the cervix or outside of the vagina. Local extension, when you see it, you see it. And this is an extension into the pelvic sidewall and almost into the sciatic notch. And what you can see as sort of a secondary sign of extension, and can be hard to pick up on an MRI subtly sometimes, is a small amount of hydronephrosis, or hydroureter, excuse me. And then of course when it's severe and you get hydroureter and hydronephrosis, you can see this on a PET CT with delayed excretion of FDG, as well as a dilated ureter on MRI. Distant metastasis you also see, and this is an example which I like because it can be very difficult to see a bone metastasis on CT. This is actually the same patient, that acetabulum, and there's actually a soft tissue component, some irregularity, and there's actually a metastatic lesion here. But on MRI you can clearly see that as an interruption of the marrow. And this is one example where MRI can be very useful in looking for bony disease. Another issue in cervical cancer, again, where size and anatomy and precision is very important, is in the case of fertility-sparing surgery. So this is a disease of young women, and when it's possible, many times, and the surgeons are comfortable with it, surgeons would like to do a trachelectomy where they don't remove the entire cervix, but they just remove the part that's involved with the tumor. And as you can see, this is a very high risk, and this is surgery in a long-term sense, because if you leave any tumor behind, you're actually having cervical cancer in a young woman. And so really the goal here is only to do this when possible. And so the strict size evaluation really depends on the surgeon that you're working with, and it's important to know what they're looking for. What's been used is a size less than 2 centimeters, less than 50% stromal invasion, and also you want to know how much cervix you're going to have left, because there's really no point in doing the surgery if the woman is not going to have enough cervix to eventually support a pregnancy. And again, this can be difficult if there's been a recent biopsy, because granulation tissue will also enhance and can mimic cervical cancer. So in summary, cervical cancer is a clinically staged entity. However, there are important prognostic features and important surgical landmarks that we can help make, particularly parametrial extension, the size of the tumor, and also in fertility-sparing surgery, exactly how much residual cervix is going to be left. So in the last part, I wanted to talk about ovarian cancer. Now, ovarian cancer has the highest mortality of gynecologic malignancies because it's usually not detected early. There's really no good screening test, as you know. Many times when we see it on imaging, it's already in an advanced stage. And one thing to just keep in mind is really, we'll talk about some features which are more malignant and some are less malignant, but it's very difficult by imaging to tell if a tumor is going to be benign, if it's going to be borderline, or it's going to be malignant. So many times we just use the term neoplasm unless we can be more definitive. So in terms of malignant features, things that have been described as large size, large nodules, necrotic component, irregular nodular septations. But again, these are not really specific. They just really help you say this is more likely to be malignant, but the identification has to be on surgery. But the strong point of MRI, in particular, when looking at adnexal lesions, is really what Dr. Poter talked about just now, which is the ability of MRI to definitively or almost definitively diagnose a benign lesion. Because if you can say this is benign or almost certainly benign, that's actually very helpful to the patient. And we can diagnose leiomyomas, which Dr. Poter just talked about, T2 shading and T1 bright in the setting of endometriomas, or masses that follow fat in the setting of dermoids. And this really actually is helpful to the patient. Early stage disease, once again, this is going to be confined to a single ovary. This is a borderline mucinous adenocarcinoma. Again, it's very difficult to tell again if this is going to be a stage 1 or stage 2. This is a more high-grade tumor. Again, on imaging looks very similar. There's a little bit of ascites, but I use this to talk about the usage of diffusion. Just like what we talked about in endometrial cancer, this can help identify other loci of disease, and this is actually a second tumor on the other side, which is much more visible on the restricted diffusion than the other one. And omental implants, of course, are very important in ovarian cancer, and you can see them on both CT and MRI. It's important that there are implants and there are implants. There are certain implants that the surgeons need to know about, which are places really around the liver and around the diaphragm, and these are very difficult to either see laparoscopically or resect laparoscopically, so it's important to specifically note these implants. more than others. And it's also important to very carefully distinguish between whether a tumor is actually an implant, which is this one. This is a EOVIS study in which you can actually see a perihepatic implant, which would be stage 3 disease, and something which actually has liver metastases, which is stage 4 disease. And that's really an important distinction to make, or an important thing to note if you can't make the distinction so the surgeons know about that. So this is a companion case because this was very surprising to me when I saw this. This is, once again, we see this is bilateral adnexal masses, and looking elsewhere in the abdomen, we actually can see some nodularity along the omentum. So this was read, and I think reasonably so, as an ovarian mass and concerning for carcinomatosis. However, when I actually saw this patient, this was 6 years later, and she was doing just fine, and then the requisition actually said follow-up borderline tumor. And I was surprised that a lesion with all that nodularity within the omentum and other places was actually a borderline tumor. But there is this entity of a borderline ovarian tumor with non-invasive implants. So something that looks like carcinomatosis, those implants could still be non-invasive. They're really just desmoplastic reactions. They come right out, and then with treatment, they do fine, and actually the patients have a much better prognosis. And so again, this isn't really, strictly speaking, our role, but jumping to say that something is a widely metastatic or a widely distributed disease doesn't always help, because we're not always right about that. So there's a final challenge I want to talk about, which is looking at these 4 lesions. And this is really to talk about primary ovarian cancer and metastatic disease to the ovaries. And there's one lesion here that's actually a primary ovarian cancer, and the rest are metastases. And I think the difficulty is actually figuring out which one is a metastasis and which one is primary. And so to tell you, this is actually metastatic colon cancer, which is the upper left-hand corner. This one is actually a metastatic pancreatic cystadenocarcinoma. Again, looks like a solid and cystic mass. This one is metastatic ovarian cancer. This one is calcifications. This one, again, is metastatic colon cancer. So the notion of metastases to the ovary is actually very important. A lot of tumors metastasize to the ovaries, and these imaging features can overlap with primary malignancy. It's not uncommon for primary ovarian cancer to be bilateral. That doesn't really help. And basically, they can look solid and cystic, particularly when they come from colon cancer, and colon cancer is a very common malignancy. But if you step back and think about it and think where we can actually make an impact on the patient, this is actually where it's very useful, because the management of a primary ovarian cancer and the management of a primary GI malignancy are completely different. So people have looked at these studies, and it's very hard from imaging to the masses themselves to tell if they're primary or secondary, but many times you can actually see the primary mass elsewhere on the CT examination, and it's important to look carefully at them. So in summary, ovarian cancer has the highest mortality, again, because it usually isn't discovered until too late. There are solid murals and septations, but these are not specific features that tell us if it's malignant or benign. But really, MRI helps us definitively diagnose benign disease. On CT, we can look for metastases. We can look for another primary tumor, which will tell them that this is a metastasis, a different type of tumor that has to be treated. And that's where we play a good role. So looking at all of these, I sort of was only able to touch on the most basic types of gynecologic malignancy, and obviously this is a much bigger topic, but really the common themes is that the staging is either going to be clinical or surgical. The initial evaluation, as was seen yesterday and was seen today, is going to be by ultrasound or a clinical exam, and the MRI and CT, though, are a very powerful problem-solving tools, but it's important when you're interpreting these studies to know how these tools are going to fit into the surgeon's evaluation, and it's important to have good communication with the surgeons as a result.